Good morning once again. We are thrilled to begin with a vibrant session that highlights the spirit of innovation and leadership in nursing. With over 30 outstanding entries, coordinating this competition was a major undertaking. Our heartfelt gratitude to Dr. Elizabeth Woki and the committed ANEICON Fellows, Dr. Ms. Jyoti Katrela, Dr. Subhagi Jadhav, and Ms. Swarnalata Patil for their dedication in making this a resounding success. We also extend our sincere thanks to our interim jury for their time and thoughtful evaluation. It could not have been easy choosing the best from such excellent submissions. Today's session features inspiring paper presentations across 3 categories: nurse-led green projects, innovations, and research, each showcasing sustainable practices, creative thinking, and impactful contributions to healthcare. We are honored to have with us distinguished panel of judges: Dr. Jaydeep Perwar, Chief Operating Officer, Vidyartha; Dr. Modi K.D., Principal, Amrita College of Nursing; Ms. Sai Balayam, Director of Nursing, Amrita Institute; Dr. Shobha Gaikwad, Academic and Healthcare Expert; and Dr. Bimla Kapoor, a leading voice in nursing education and research. We now invite the finalists in each category to present their work, and each speaker will have just 7 minutes. Please keep an eye on their time. So, category 1, nurse-led green projects, reducing carbon footprints. Finalists: Mr. Kiran H. Kulkarni, Ms. Beulah Robinson, Ms. Neha Vishal. So we will begin with Mr. Kiran H. Kulkarni, and followed by him will be Ms. Beulah and Ms. Neha. So over to Mr. Kiran. Kiran H. Kulkarni. Is he here? Thank you. I request all the judges to be on the dais.
Namaste and good morning to all. Greetings from HCG Sucharaya Hospital and to all ANEICON members. Namaste to jury members. I thank my organization and ANEICON for giving me this platform to talk about small project, what we did in a North Karnataka in a small hospital of 250 bedded. I also thank my team, including me and our Chief Operating Officer for putting me a small project on for eco-friendly or green project, which we started on a gloves usage, and efforts were made to reduce the usage of the gloves from the hospital. A topic had been glove of confidence on a safe approach to reduce unnecessary gloves usage in the healthcare sector. As all of you know that in healthcare, we believe more on personal protective equipment usage. It has got a vital role in infection prevention, but it is overuse, particularly of a disposable glove, has a significant implications. While gloves are essential in high-risk situations, their widespread use in a low-risk and non-invasive procedure often stems from a habit or pursued safety rather than a clinical necessity. It's all we have observed. Glove is mostly used for thinking it's a protective layer. The Go of Glove initiative is a patient safety and environmental sustainability strategy aimed to promote a rational glove use. It is encouraged the healthcare professional to rely on effective hand hygiene, which is a basic mantra, what we all follow in infection prevention, rather than necessary gloves application for low-risk tasks. The shift not only uphold the infection control standards, but also significantly reduces the medical waste, lower the cost, and supports the global sustainability. By minimizing the glove overuse, we can reduce the environmental footprint of a healthcare poster to more mindful to culture protection and empower the staff with confidence to care safely without relying on gloves. Go Glove Off is not about using the fewer gloves, it is all about using them better. Our study was aimed patient safety and infection control. Mainly, we were focused on promoting the glove usage based on the clinical needs, and we wanted to reinforce on the hand hygiene, and we wanted to reduce the cross infection. Of course, it had a point of cost efficiency also to lower the cost of usage of PPE wherever is not required. Environment sustainability also, we had to decrease the gloves wherever it's not required. Operational efficiency, because the resources of gloves has increased after COVID-19. The objective was mainly focusing on to improve educate the nurses about appropriate glove usage with focusing on WHO 5 movements. We also had to reduce the glove usage in non-invasive and low-risk procedures by 30%. To improve the staff confidence in hand hygiene as a primary method of infection prevention. To track the glove usage, cost, waste, to monitor environmental and financial impact. Also, we had an objective. What we did in our project was, first thing is we did the education part of the staff, focusing more on our hand hygiene practices. We did 5 movements of hand hygiene, and clinical indications are important for using a gloves wear. And second thing we introduced, very important thing is introduction of a glove of procedure list, which is a very important list why the nurses should know, we thought. So procedure where the gloves to be off. Taking a blood pressure, temperature, pulse, means all vital signs, administering of oral medication, no gloves required, assisting with feeding, making or changing of a linen wherever there is not soiled, transportation of the patient, and performing hand hygiene be focused, and in a clerical documentation shouldn't be using, and patient wherever the comfort supports we shouldn't be using it. Removing of foot plates, non-sterile dressings, we focused. This were displayed. So visual reminders were placed, and optimizing a glove accessibility means we restricted the availability of the glove. It was kept in a drawer, highlighted it, and we monitored on a monthly basis how many gloves are usaged for each unit. The study was conducted in 2 ICU settings and 2 ward settings. It included almost 50 nurses. The study was conducted between June 2024 to December 2024, and it is also continued with another 2 ICUs and 2 wards this year. very important display where how decision flow chart for a glove usage. The mainly focus was if you want to use a gloves, when to use. If you are not sure what to do, you can use a gloves whenever there is a blood or body fluids you are coming in contact, whenever you are coming in contact with a mucous membrane and non-intact skin and contagious materials if it is required. So we also highlighted glove use do's and do not, where not to be used. This was displayed in each hand hygiene station. There are 5 moments of hand hygiene in the glove. Next to that it has been displayed in all the hand hygiene. Of course we had challenges. People were worried about the infection and that was a behavior. We could able to interact, almost we did 6 sessions and interactions. We had a resistance to change, a lack of no audits were conducted past, resource availability was we could find some differences, not great as such. We could see overall hand hygiene was increased from 60% to 90%. Glove usage was high risk areas from 55 to 80% has been seen. And we also have seen hand hygiene after the patient contact has improved 70 to 90%. Hand hygiene before patient contact was 63 to 90%. Other than 5 moments of hand hygiene has improved from 50 to 90%. Correct glove usage was from 60% has improved to 85%. We could able to decrease the glove usage almost from 45% where it was earlier 70%. We did it. The confidence level was checked using a Likert scale. It is the self-rating of the staffs, and the staff have rated. So pre and post, we could see that the most of the confidence level of the nurses have improved. And also we could see the environmental financial effect. So there were per month we could able to save almost 58,000 rupees. In 6 months we could able to save around 7.5 lakh. With that, I conclude that in a small city like Hubli, we have done this effort. A little nurse can contribute using a gloves and can bring a footprint less. We thought that each glove can bring 6 times of carbon production when it is generated as a waste. So I request everybody to put a small effort where we can reduce the burden on this earth. Thank you for giving this opportunity.
Congratulations, very good study. What was the sample size given?
We have taken up 50 nurses as a sample size, madam, for the confidence level assessment.
50 nurses.
50 nurses. The study was conducted in 2 ICU settings and 2 ward settings.
Okay, thank you so much.
Thank you.
Just one question. What was the exclusion criteria?
Madam, all the one who is not ready to participate in the study, if they have concern to use the gloves and they are not very clear about the glove will prevent an infection or not. If somebody is not willing for the study, we are not taken. I think there are 5 nurses.
Okay, I just want to know about patients with infectious diseases.
Yes.
Then normally we will have to use gloves in some other areas. Okay, where you said need not be used. Maybe sometimes we have to use. Did you consider that?
Definitely, madam. Wherever there is a safety concern, gloves must be used. Okay. Glove only to be avoided in a low risk area. Glove can be avoided where there is not in direct contact with body fluids.
Okay, thank you.
It's more of awareness what we need to bring with self and to the society. Thank you, madam. Thank you, Shuri ma'am. Thank you all.
Now over to Eula Robinson. Inviting Eula Robinson to be on the stage.
Namaste JD to giving us the time. And I'll thank my organization for giving the huge platform to present my views. Myself, Vila Robinson, heading nursing in SCG Airport. My project is Threading Sustainability to Surgery, a nurse-led movement suit project. Our background for that project is taken. Non-woven suits are primarily diagnosed for one-time use hospital generated. So, background of my project is non-woven suits are primarily designed for one-time use hospital generate thousands of pounds worth of waste per year. Most non-woven suits are made from polypropylene, polyester or polyethylene, which are petroleum-based plastics. These materials take hundreds of years to decompose, contributing to long-term environmental harm. After a single surgery, these gowns are discarded as biomedical waste, which often end up in landfills or incinerators, both of which have serious environmental repercussions, like long decomposition time, microplastic leaching, release dioxins, CO2 and other toxins into the air, overall leading to carbon emission and carbon footprint. In an era where environmental responsibility is not just preferred but becomes imperative, this nurse-led initiative reimagines surgical attire through a sustainability lens with an vision to the development and implement of reusable woven surgical suits engineered to meet the rigorous demand of the operating theatre. So we redefining protection, performance and planet conscious care, one woven thread at a time. Project overview is environmental stewardship, durability with purpose, surgical team comfort, nurse as a change agent, infection control and compliance, ensuring the material are laundered and autoclaved appropriately. Behavior and cultural shift, change management strategies, awareness campaign and staff engagement to promote sustainable behavior with surgical team and across the hospital. Economic impact. While initial investment in woven attire may be higher, long-term saving from reduced procurement and waste disposable costs. Patient satisfaction required, so sustainable approach reduce cost for the patient. Data-driven outcome, a monitoring framework will track user cycle, laundry and autoclaving efficiency, cost-saving waste reduction, and staff satisfaction to ensure continuous improvement and scalability of the program. Our objectives to taken to evaluate the environmental impact to transition from non-woven disposal to reusable woven surgical attire. To assess the cost effectiveness of reusable woven suits in terms of procurement, laundering and waste management, to explore the role of nurse as change agent in promoting and implementing sustainable practice in surgical setting, to measure surgical team satisfaction using woven material. We face some problem when we go through this project, like high initial investment when we start that project, behavioral and cultural resistance from the nurses and surgeons, consistent laundering standards, perceived hygiene concern, delays in laundering turnaround time, consistent inventory management, ongoing audits, we do lack of infrastructure for in-house laundering issues. Results of this study is the cost effective, environmental impact is biomedical waste cost. Non-woven material cost per month 1,000 woven suits we use. Woven material cost 3,000. For 6 months is 1,000 for non-woven material and for wool material 1800 only. Comparison on the cost, single piece first by woven suit is costing 550 rupees, non-woven is 150 rupees, 900 rupees for 6 suit and 3300 rupees for 6 suit for non-woven suit. Per surgery 6 suits we use, so 130 rupees re-washed for each suit and 900 rupees for non-woven suit. For 25 surgery in a month we perform, so cost for woven suit is washing 3168 rupees and non-woven is 22,500 rupees. Including CSSD cost, then total cost of woven suit is 8,143 rupees and non-woven suit is 24,300 rupees. So woven suit is also cost effective. So results, nurse as a change agent, we go with this slide. So awareness of sustainable practice, we go 90%, active participation in implementation and leadership in sustainability initiatives. So overall satisfaction is 90%, comfort 92%, age movement is 85% and breathability is 88%. So conclusion of our study is the transition from non-woven disposal surgical attire to reusable woven suits represent a meaningful step towards sustainability in healthcare. This nurse-led initiative not only reduces environmental impact and procurement cost, but also preserve clinical performance standard and enhance user comfort. Overall, the project illustrates that sustainable practice can be successfully integrated into high-stake environment like operating room without compromising quality of care or safety with attention to cost, helping patients take home more satisfaction. It is a study with a 140-bedded hospital in Jaipur. Thank you so much.
These years or you were doing it for it is outsourced? Like how did you come to that cost? Outsourced?
Our laundry is outsourced.
Outsourced.
Congratulations, your study is really, really good. A project is amazing. I just wanted to say, if you can expand this project or to find out what's the solutions of your problems which you have shown in the picture, that you can do a great do that, because that's the solutions we need to know, and you have very well projected that what was all these problems.
Thank you so much. Definitely, sir, will lead by this.
Thank you, Ms. Lula. I invite Ms. Neha Vishal.
Good morning, one and all. I am Neha Dive. I am working as a manager nursing education with Sayadri Group of Hospitals, Pune. The name of my project is The Green Horizon, Save Paper, Save Tree. The background of my study is our Go Green project focuses on promoting environmental sustainability by encouraging eco-friendly practices like reducing paper waste, conserve energy, water, electricity, and promote a healthier environment across our 10 units of Sayadri hospitals and the upcoming units as well. The Go Green project initiative is taken by the Education Center, which is one of the units of our hospitals, to create awareness, implement training programs on conservation of light and electricity, hands-on training on implementing paperless documentation and initiatives which reduces paper usage. The objective of this study is to implement paperless documentation, to educate and make aware the nursing and other departmental staff for the paperless documentation, to reduce the cost and to conserve electricity and water. This project was started 6 months ago, that is from November, and it ended in the month of April. There are 10 units of Sahyadri hospitals across Maharashtra. The data was initially stored in a hard copy format, consuming lots of paper, box files, printer that was required, cartridge, consuming lots of space for storage, consuming lots of electricity and time. After implementation, the below mentioned data is paperless now. I would like to list down the data that we maintain at our hospital. We do have a nursing induction program. There is a training data, a calendar that has been circulated through Human Resource Department, a nursing training calendar that has been made or created in every units of Sahyadri hospitals by the respective CNS and ANS, and there is a corporate training calendar as well. There is a monthly training report that has been sent from each and every unit. There is a common feedback form for the trainings that have been conducted, a copy tracking sheet, NQI data, clinical, non-clinical. There's a daily nursing report. Drug studies have been conducted across the units every month. We have also reduced the use of paper cups and tried to implement education on conservation of light and water for the new joinees. The problems that we faced earlier before implementing the QR scanners were, there was a storage issue. The data required lots of physical space, which is costly and difficult to manage. There is also a security risk when we are storing the data. There was a limited access and sharing. Physical documents cannot be easily accessed, and there was difficulty in accessing the documents and difficulty also in taking a backup. As there are large amount of papers, there are chances of data to be misplaced, misfiled, and making the retrieval difficult. Printers were required for printouts, thus increasing the operational expenses, consuming large amount of paper leading to deforestation, leading to, and there was also difficult to track the data. Data was risked at damage from fire, water paste, and an unauthorized access. So how did we work on data to implement paperless documents? During the nursing induction program, we do have a pre and a post test. So the QR code was being generated and total 11,440 papers were being saved. As I'm presenting a data for the last 6 months, there were 62 batches that were being covered for the last 6 months. Total 1,430 staffs were covered for nursing induction program. Total 8 papers per individual were been given to them. 4 for the pre-test, 4 for the post-test. So this is how after generating a QR scanner, we have 11,440 papers that we have been saved for the last 6 months, and 8,648 cost was being reduced. Next is the training data. As I said, we do have 3 different departments who generate the training calendars. So the Human Resource Department, for the 10 units, there were 60 registers that were initially used, and after creating a link, we have been reducing 5,820 rupees have been saved. The second training calendar, which is generated at the unit level from the respective ANS and CNS, we have been saving 5,820 rupees after every 60 registers, and for the corporate training calendar, Again, 5,820 rupees are being saved after 60 registers from the 10 units. This is again a monthly training report. The link is also being generated for this. And 10 units, 60 registers were being used, and we have been saved 5,820 rupees over it. The common feedback form, as mentioned, total 62 batches are done. So 1,460 candidates were covered in the 62 batches, and the paper that has been saved is 1,430. This is also a copy tracking sheet. So we have been saving again 5,820 rupees for 60 registers that were used for last 6 months. This is our NQI data, clinical and non-clinical. Same with this. This is a daily nursing report. We have again created a link for this report where the 60 registers are being saved. The result is the revenue development. So 28,623 rupees in first quarter have been saved, and 28,623 again in the second quarter were been saved. So the total exposure of 57,246 rupees has been saved in the last 6 months. In conclusion, the Go Green project plays a vital role in promoting the environmental sustainability and encouraging responsible practices to protect our planet through initiatives like reducing waste, conserving energy, recycling, and promoting eco-friendly habits by raising awareness and implementing sustainable solutions in our daily lives. We contribute to a healthier environment and a better future for our next generation. The success of this project depends upon continuous commitment and collaboration from individuals. Actions from the individual communities and organizations. The data is now saved and shared with the other units as well. Thank you. With this, I finish with my presentation.
Very good study again. Lots of efforts. I will not study the project, I understand that. Just wanted to ask about the paper cups. Is it only for drinking water or giving to the patient with medicine? What is it? Paper cups. You save a lot of money on that also.
Yes, we have saved these papers, ma'am, through different data that were physically.
Paper cups?
Paper cups, yeah.
Disposable?
Yes, we do had a paper cups earlier. We provide tea for the people who come for the training programs.
Oh.
And now we have reduced it with a stainless steel
Thank
cups.
you. There was a cost involved in developing the links and is it an in-house development software already existing, or did you do something special to change all such online?
No, we had it. We did not had it earlier. It was there, but it was not used full-fledged. So the links have been created. We are now into a Zing app. We are getting that so that all the units can have their data into one folder again.
So
that
this
is
is yours. This is your own developed, or you got some software in it?
We
Some
got
cost
this-
involved in it.
we got the software now. Yes.
Thank you
ma'am.
very much.
Thank you.
Good project.
So I think in continuation of ma'am's question, we just wanted to know that if you are using all this technology, digitalization, did you compare the cost of the softwares which you have purchased, these digitalization are you using for the protection of the data? Did you compare the cost paperless versus with the paper?
So of course the cost was being checked, and maybe for that period of time the software cost would be more, but if we are using it for the long term, the cost might reduce in the future. Yes, thank you so much.
So category 1 is over. Now we are next to category 2, nurse-led innovations, transformative solutions in action. So the finalists are Dr. Payal Kapoor, Ms. Sujata, and Ms. Preeti Nanda. So I request Dr. Payal Kapoor to be over here.
Good morning everyone. I am Dr. Payal AIMS New Delhi. So thank you ANEICON for giving me this platform for sharing my innovative work. So this was our project, PhD project, which I have done at AIMS College of Nursing as a full-time PhD scholar. So what we did, we developed a mobile app, Upchar, which was AI-enabled health education system for advanced cancer patients receiving palliative care. So we used this because mobile app, they have the ability to transform they can empower the outpatients with accessible, user-friendly applications to improve patient outcome. So we developed it for advanced cancer patients because cancer patients, they are prescribed with a variety of analgesics and adjuvants, and taking so many medications at a time or starting to take up a new medication, it becomes challenge for many patients. So when they are not able to take the medications on time, it will lead to poor adherence, recurrent pain and other symptoms which they experience, which will ultimately lead to poor quality of life, and they will come to us again and again for admissions. Ultimately, it will cause burden on caregivers as well as healthcare facility. Poor knowledge about the disease, the analgesics or adjuvants, it is another contributing factor. So with this objective of improving the compliance of analgesics and adjuvants, and also to improve the knowledge about cancer pain and its management, and thus we focused on improving the overall satisfaction of care provided among advanced cancer patients receiving palliative care at a tertiary care center. So our app, it stood for, we have named it as Upchar, and Upchar stood for Understanding Pain and Palliative Care, Health and Rehabilitation. So this app was developed by AIMS New Delhi in collaboration with ICMR, Indian Council of Medical Research. So this is the web page of our app, and the features of this app were settings to upload the prescriptions. Whatever prescription the palliative care physician was giving, we were uploading that in the app. Then it used to give, according to the schedule, it was giving alarms. Then it has setting to track the medication intake, and also the patient could rate their daily symptoms. And also it had reminders for follow-up visits, like patients used to come to us after 15 days, so we were also giving the reminders for that. And then AI-based health education system. So this is how the mobile app looked like in their phone. It has various components, and the patient can view their prescription, like whatever prescription the physician had given, we had uploaded that with the dosage, with the timings, with the schedule, so that the app was giving them reminders, and then the patient could give us the adherence. Like the patient, it was very simple for them. Patient just had to rate 0 if they have not taken, 1 if they have taken. That is how the patients were giving us the adherence. And not just that, the patient could also give their symptoms, like they were experiencing pain, nausea, vomiting, constipation, which were common side effects faced by them. So they could rate that on a very simple NRS rating scale of 0 to 10. They just have to slide this bar and rate their symptom. And then not just that, we as healthcare professionals, we could also track the symptoms experienced by them and the medication adherence. Whatever the patients were giving us the symptoms, that we could see as the graphical representations of the symptoms, so which made a lot easier when the patients used to come to us after every 15 days. So apart from this, it had AI-based health education system. There was 4 components for that. We had uploaded the entire content in some headings, so patient can go through that. Then the patient can search, and while the patient was rating their symptoms, if they experience moderate to severe symptoms, automatically a help used to be generated, like you are experiencing more symptoms, do you need additional help? And the related health education component was displayed on their screen, and if the patient wished, they could read that. And also they can increase or decrease the font size. It was bilingual, so they can change the language from English to Hindi or English to or Hindi to English, which made quite convenient for them to use this. So in the implementation strategy, we did an RCT. It was basically an RCT in which we had 2 groups, mobile app-based prescription group versus the conventional prescription group, and then we have checked their adherence, satisfaction, and also knowledge between the 2 groups. So we had provided them with a link to download the mobile app. So once they downloaded the mobile app, they could be using it, and then with the help of computer, we had a web page. So with the help of web page, the entire medication prescriptions or their data we used to put in the website, and which automatically reflected in their mobile app. So when we were feeding the data, it automatically generated a user ID and password which was shared with the patient, and then through the website, when they logged in through using this password and user ID, all the details which we had filled, it would reflect in their mobile phone. So, and the impact, we found that between the two groups, the compliance was better in the mobile app-based group as compared to the conventional group. The knowledge was better, which helped them, which empowered them in managing their symptoms at home. It also reduced the intensity and frequency of symptoms experienced by the patients, and the overall satisfaction was also better in the mobile app-based group as compared to the conventional group which were using the conventional prescriptions. And yes, we had also provided booklets for health education to the conventional prescription group. And not just that, after 6 months we also did a qualitative study to know about the experiences of using the mobile app, and we found, the patient found, they reflected in their verbatims that they found the app to be good, very easy to be using, and it improved their compliance because the reminder system, it was very consistent, so that they do not forget their medications to take them on time, and also the follow-up reminders help them to maintain consistency in coming to us. And they said that they could track their symptoms, which helped them to proactively manage their health. And with the AI-based health education, it was better because every time the pop-up come, they used to read something, and overall they found this was a patient-friendly initiative and it should be given to all the patients. The only problem we faced was updating, because after 15 days we had to update all the medications. So you can see this is the knowledge which was better in mobile app-based group this is the knowledge, and this is the adherence of all the medications which was better in mobile app-based group as compared to the conventional prescription group. And in evidences, earlier there were not many studies, but now there are many studies. So I have listed a few. For example, Karaslan, they found that in adherence of oral cancer agents, the mobile app was found to be better. So similarly, the other, in all the aspects, there are these, better results, and we can conduct similar studies on other diseases like hypertension. Mobile app can be used for chronic illnesses, and this app can be used because this is a dynamic app, and mobile app should be implemented in clinical practice. And ultimately, I would say that digital health is transforming the future of medical and nursing sciences by driving innovation, enhancing connectivity, and improving the patient care delivery. So it should be adopted in our routine practice, and also nurses should find innovative methods how this AI-based technology should be used in our own practice. Thank you very much.
Nice study. Just one question I have. In case the patient's mobile is switched off, is there any reminder given to the caregiver or someone? How will the patient know then? Because it's totally mobile
Yes.
app when I talk about the medication.
So no, our reminders are only through, because we have used this mobile app, and in our experience of using this app, we never found this thing, that the mobile app was switched off. And another thing, this was again one important aspect of this app was this could be used without mobile data. They could use it offline, and once they are putting their symptoms, they just need data for synchronization. So once synchronization is done, whatever data they are feeding, it will come to us, and whatever we have changed, the listing of medicines, it will go to them. So it had the ability to work on offline mode.
Okay, very nice theme as such, and these days, we know that everybody is after AI and health. I just want to know what sort of interprofessional collaboration you had for preparing this app.
So ICMR supported us because it was ICMR funded project. So the website and the entire data, it was saved at ICMR headquarters.
ICMR,
Indian Council of Medical Research, New Delhi. So it was a partnership of AIIMS New Delhi, College of Nursing, Palliative Care Department of AIIMS New Delhi, and Indian Council of Medical Research, ICMR, headquarters New Delhi.
Now, did you discuss with the doctors who are prescribing?
Yes. So my co-guide was Dr. Rakesh Garg, who was professor in palliative pain and palliative care. So he was prescribing, because as of now we cannot load directly all the medications into the mobile app because it is not legal. So they had the paper prescription, but we have provided them support by uploading their prescription into the mobile app.
Okay, thank you.
Thank you, Dr. Pai. Over to Ms. Sujata.
Namaste to all present here. I am Sujata, working as a Chief Nursing Officer, HCG DRT. We have Anita Rashmi. I am presenting as a innovations of post-operative care from implementation of exercise tracker using Google Forms. I want to thank this platform, Annie. Then I want to thanks to HCG and my team, Punita ma'am and Abdul sir. Is it like my team, like project team lead is Sujata, then members Rashmi as an infection control nurse, Divya as a register nurse, then Dr. Gopinath as a surgical oncologist. The name of organization Healthcare Global Enterprises, Double Road, Bangalore. The study innovation is 90 days. Introductions. Start with long, strong book. Imagine a world where simple digital form would prevent the post-operative infection and save life. Today, we are making the reality. For introductions, surgical wounds are key part of recovery. Poor monitoring can lead to infections, delayed healing, and serious outcomes. We are introducing a low-cost, tech-driven solutions using Google Forms as a surgical site tracker. Need for innovations. Why do we need this? By using Google Forms, we also patient to self-report and clinician to access update instantly, improving care and outcomes, especially in resource limited settings. Our idea makes wound monitoring more accessible, more efficient and cost-free. Objectives are fourfold, like to determine success in patient engagement using wound assessment tool, to access the time of clinician to respond to patients, to determine the early identification of surgical site infection, to compare the effectiveness of existing SSI tracker was Google Forms based tracker. So let me walk through how to innovation actually works from the surgery to support. The patient undergoes surgery. The patient receives Google Forms link of post-operative wound assessment care during discharge. The forms include general patient information, image for visual guidance, specific questions, and wound healing complications, introductions, instructions of whom, then how to contact if any issues are there. The patient completes submit the form. For the submission trigger pop-up alert, the infection control nurse review the alert and she will coordinate with the patients through the telephonically and she will update the guidance and further steps. Evidence. Now let's look at real world evidence how this Google Forms based tracker is making an impact in surgical site infection prevention. So these are screenshots from the Google form based on SSI tracker. This is actually screenshot. The patient can upload real-time images, reports symptoms like redness, swelling or discharge, if even use the visual scale of pain. That Excel based on SSI tracker manually updated, road to delays. lacks real-time visual data and requires the staffs enter the interpreted information. Implement and strategies. So how to workflow is on the day of discharge, the clinical nurse specialist, she will inform the ICN, she will assist the patient and she will collect the baseline data and she will educate how to use the tool. After discharge, she will remind the tool 3rd, 17th, 15th and 21 day after discharge. Once the patient submits the response, this wound to be viewed by the ICN, clinical nurse specialist and surgical register. The patient would be advised whether the wound is healthy or have to return back to hospital. Impact and outcomes. Here the measurable outcomes from using our surgical site infection tracker over 150 patients to understand the impact of our innovation. It is important to look at who used and how they engaged with it. Frequency of age. This bar shows the patient age group within the majority between 31 and 50 years indicate the tool's applicability across the age of ranges. This chart shows 72% of responding actually engaging with the wound tracker. Gender distribution. Similar distribution between gender, 72% male and 28% female. Reaffirming that this tool includes the easy use all the patients. Like type of surgeries, the pie chart shows tested across multiple surgery categories like general, breast cases, ortho and endocrine. Here we have innovation truly shines, real impact, back data, the patient engaged, the first graph shows strong patients engaged, of 150 patient responses, 31 patients have submitted the form, 26 trigger alerts, 22 need follow-ups, and most readmissions were prevented in 19 cases, contributing the 83% of completions rate. The time of responded, this chart shows the consultant responded is 39% within 1 hour and 28% within 1 to 4 hours. The early identifications, we see the success early identification of infections. 23 patients are flagged through the form, 19% confirm the clinical reviews. We have the challenges like digital literacy. Some patients, especially elderly, struggle with the smartphone and access, internet connectivities, unable to access. Then patient complaints forgot and delay filling the forms. So while our current model has shown strong outcomes, we believe innovation must be never stopped and have to plan elevate this even further. Conclusions. To sum it all up, this isn't just a tech solutions, it is a human-centered innovation. The surgical site tracker developed collaboratively with the surgical team in no-cost, user-friendly tool. The improve the patient engagement enables early complication detections and streamlines data collections. This innovation means collaboration, better healing, become just possibility but a promise. Thank you, ma'am. Thank you, ma'am.
Okay. Again, a very good study, very practical study. My only question is what happens to the people if they are not literate? Did I make myself clear? If the people are not educated, literate, they cannot read and write.
So my ICN and clinician nurses, they will ask the wound assessment like pain, discharge, any redness, anything, they will coordinate, then they will inform the consultant team. Thank you, ma'am.
Thank you, and very good morning to all of you. We are nurses. We are not only caregiver. We are innovator. So being an innovator, I am representing the entire nursing fraternity who is standing here, sitting here. That nurse, as an innovator, what they can impact, what impact they can make it. So the project is something which is based on the practical innovation idea, which we all struggle. I struggle, you struggle, and all. It's a pre-shift hurdle in the intensive care unit, and which definitely helps to build up the operational excellency, and it is led by the nursing team. Little more about this project when I speak. That this particular project is very much important because the care setting is getting changed, care model is getting changed, and also the nurse-patient ratio. So it is a call for the hour. We need to think about how we can involve the multidisciplinary team for the benefit of the patient and patient safety. So more to talk about this particular project, we work in the hospital where we have 36-bedded ICU and very busy ICU, and we always used to face this challenge that patient is getting shifted late towards the night, and which is causing a lot of patient safety related issues. So to categorize this particular project, the need was felt in under 3 categories. The first category was that it was disrupting the patient's safety. So we all, as a nurse, afford the patient safety. We had issues in terms of accidental delineation among the ICU shift out patients, and fall, and central line related bloodstream infections, many more as we talk about it. Also, in addition to that, another part of this particular project where we felt the need because the patient flow management was getting disrupted, our ER was getting overloaded with the patients who were waiting for the ICU shift out. And also the third, but not the least, that it was optimization of the bed utilizations, which we look forward. So categorizing all these needs, we felt like we need to take up this project in our hospital. So of course, whenever we take the project, we have to make sure that we give the numbers, because this is the goal and objectives which we wanted to derive at the end of this 3 months project. So October, November, December 2024 was the pre-intervention, and then we put this our innovative idea pre-shift hurdle in ICU, and we evaluated the outcome in the January, February, March month, and we are continuing to do so. So these were our outcomes, which talks about we wanted that 75% of our patient transfer should happen at least before 6 p.m., which gives enough amount of time for the patient to get accustomed with the environment where patient is getting shifted. We also wanted that our ER bottleneck should be reduced by 2 hours, not more than that, and central line days must be reduced because we found our CRBC is one of the leading cause was central line days was more. And also, of course, 0 incidence of patient falls, return to ICU within 48 hours should be also less, and accidental delineations, which is the nurse, as a nurse we are supposed to be answerable for this accidental delineations. Moving ahead, this is about the project which I like to talk. What innovation idea we put it over here. So this was in the four steps. The first steps, the innovative idea, we made sure that the doctors write in the progress note, the patient is going to be transferred. We need an order over here. Second, what we did it, like we decided the time, which is approximate 2:30 p.m. because based on our round timings, that everybody, multidisciplinary team members from the various categories, starting from the clinical nurse, ICU joint director, and also the bed management, also the operations. It is not only the nursing, also the infection control team. So multidisciplinary team members of 7 people would come in the ICU at the patient bedside, and we would introduce the patient and the family members, so that ensuring the patient engagement and talking about the purpose of this particular visit. And then this, as a nursing supervisor was the leader of this particular project, would comprehensively analyze that whether this patient is really fit for shifting in terms of 5 different categories. What is the mu score? Because ultimately patient comes to the ward, we follow up with the mu score. What is the patient's consciousness level? What the patient's having the invasive lines, can we really remove it? Is it required to do so? And more other things as we speak about it. So once they evaluate, if the nursing supervisor finds that it is not really so-called patient is not ready, he can put his opinion in front of the clinical leaders who is part of this multidisciplinary team. And mutually when it is agreed upon, we come to the point that yes, patient will be shifted. So that's this part A. Part B, the bed management, and operation team who are present at the bedside they also discussion would happen based on the patient's requirement. What would be the bed? Like, is it going to be at the next to the nursing stations? What would be the patient acuity level? What would be that dosing monitoring or continuous monitoring devices do the patient require? All this decision would take place in the ICU at the bedside. Third part of this particular project, now the ward, once we decide everything bed is given, so now the ward care team members, the nursing as well as the doctors who is going to take care of the patient would come to the ICU, would take handover and take over in the ICU. At the same time, they will look at the patient and evaluate that with the patient, how is the patient. So patient can get connected with the clinical team and they feel more comfortable that when they are getting shifted. Part D, we do not end up over here. Once the patient is shifted, the ICU team leader, who is in the night duty, time is given between 1 a.m. to 2 a.m. They will come and look at those patients who are shifted and just to check that whether the patient, all this night time, all this mishap happens, whether the patient, all the safety parameters are in place or not. So this is the part 4. So this is the impact. Okay, based on this, we could do this. Our ICU shift out patient happened between 6 p.m. as a pre and post. Percentage of ER shift out within 2 hours we could achieve based on our benchmark decided. Number of central line days reduced, so the central line infection did not reduce. We have to work on more because some other factors are associated with it. Also, the accidental removal of the line also decreased because the patient got enough time to get accustomed and more training, more education. Because night time after 10 o'clock, if you train, it does not get registered. And also, return to the ICU also greatly it is reduced. And number of fall, it is drastically reduced, it became 0 and we are continuing to remain 0. Yes, challenges were there. We wanted to find the challenges by taking the survey of this multidisciplinary team who comes and who are visiting the patient and being part of this team. So they spoke about 2 important factors which we need to work on it. That available bed category of the patient is not available, which we are working on it. Second category, they spoke about that the timings at 2:30 may not be appropriate for all. So going forward, we have introduced the GAST tool from understanding the aspiration list to, because this is one of the reasons for returning the things. So this will help us to prevent the aspirations, of course, and also we have put it forward that doctors should decide about the transfer 24 hours well in advance as the discharge process. And also revenue analysis, we are continuing to do it because it has got a huge impact on the revenue because resource is getting utilized for the ICU patients. And of course, code blue and code RRT among these ICU patients has reduced. So that's all about my project. As a nurse, as a ANI members, we fight the fight to uphold the patient safety. So we must all continue to do so.
It's not actually a question, but again it is a very practical and a good study. Excellent. We are proud of all of you who are presenting. My only question is that it may be possible for the nurse practitioners, critical care nurse practitioners, but do you have a freedom to tell to the doctors that this patient should be held up and not sent and all that, So because we know that what kind of ego our doctors have in the critical care units. So maybe during your study, did you face any problem of like that?
Yes, that's ma'am, the team members who we selected, we kept joint director of the ICU. So who is the joint director? He was having the ER also. He was managing our ER. So he understands the pain of our ER. So the patient in the ICU who is going to be from the ER who is going to be shifted to the ICU, they are occupying the bed. So they are having issue in the ER because it was creating bottleneck. So the person who was joint director who is managing both ER and ICU, he is answerable for this patient flow management for the both. So we selected him, so he could not, he was a part of our team members. I mean, that's what the selection of the team member, we took it in. We did not take the director of the ICU.
Thank you. I got your point because you included him as a part of the team. But my only concern is that whether we'll be able to do until and unless we have the nurse practitioners practicing that, or our nursing CNOs give that freedom to our nurses working in the critical care unit. Thank you so much.
Thank you.
So category 2 is over. Now over to category 3. Nurse-led research, innovate, investigate, impact. So the finalists are Ms. Bhavina Verma, Ms. Sharon Joseph, and Ms. Joy Kesia. So I request Ms. Bhavina Verma to lead for the presentation.
Good morning, everyone. Good morning, Uncle. I'm Bhavna Verma from Sadhguru Hospital. I'm working as a lactation nurse. So, today I'm going to present this research title. The name of the title is Exploring Prevalence of Sensory Sensitivity and Parental Perceptions Regarding Behavioral Pediatric Feeding Problems Among Children with Developmental Disabilities, a cross-sectional study. And as we all know that the developmental disability prevalence appears to be significant worldwide. In the world, 240 million children they are suffering with developmental disabilities. And in India also, according to Rashtriya Bal Swasthya Karyakram, 10% children are there in the India with developmental disabilities. And in the previous study, it is found that the children without disabilities they are having sensory issues like ranges from 10% to 55%. Anecdotes and all study also suggested that the children with disabilities they are having the sensory sensitivity in terms of hyper and hypo. It accounts for 40 to 88%. And Revy and all study also suggested that the children with special needs they are having the feeding issues or problems around 30 to 90%. And that eventually leads to the bad parental and child relationship, more coercive feeding techniques, and this leads to child's maladaptive feeding behavior. So the need of the study is identifying these sensory issues in terms of hyper and hyper sensitivity, behavioral feeding problems, parental perceptions. They lead to more effective interventions in terms of dietary, behavior, and other sensory interventions. This leads to the reducing the impact of challenges on the child's growth and development. So the objective of the study is to study the prevalence of sensory sensitivity, behavioral feeding problems, and parental perceptions among children with developmental disabilities. And second objective is to study the association of sensory sensitivity, parental perceptions with the demographic variables. After taking the ethical approval from the Sadhguru hospitals, the study design was quantitative approach and descriptive survey. The study was done in Child Research Center of Sadhguru Hospital, and the population was from the children with disabilities. There are the children were diagnosed with 6 disabilities. First is ASD, autism spectrum disorder, ADHD, intellectual disability, cerebral palsy, specific language disability, and Down syndrome. And the sample was the children with these disabilities among the age group of 6 to 11 years of age, and the sample size was calculated according to Cochrane formula, and the prevalence of 10% is found to be 138. The study was done with the sample of 150 samples. Inclusion criteria includes the children with the age group of 6 to 11 years, and those who are attending Child Development Center, and those who are diagnosed with these disabilities, and those who are willing to participate. And exclusion criteria, the parents who do not understand Hindi or English. Now coming to the statistical analysis, after taking the anthropometric measurement, calculation of per BMI for each category is done according to IAP-AP, and the data entered into Microsoft Excel, analyzed using SPSS, and categorical variables and chi-square was applied and analyzed. The tools which are used for this research was demographic structures intervention tool using weighing scale and studiometer also, and the two standardized questionnaire tool was used, that is PGSQ, Parent Completed Glasgow Sensory Questionnaire tool, and BPFAS, that is Behavioral Pediatric Feeding Assessment tool. And both the tools were used by using the interview technique, and the reliability was already established in the previous study, and they are already validated in Hindi, and they are after taking the permission from the author, they are used. The time taken was approximately 40 to 45 minutes with this interview technique. So the outcome variable is sensory sensitivity. It is the internal sensory experience of the child in terms of hypersensitivity, that is a heightened response to the sensory stimuli, resulting in sensory avoiding behavior, and hypersensitivity, that is a reduced responsiveness to a sensory stimuli, resulting in sensory seeking behavior. So this is all about sensory sensitivity. And parent complete class sensory tool assessed the behavior of the child during meal time and the parental perceptions. So the tool assesses the parental strategies and feelings along with the child's behavior during meal time. This is the 35-item questionnaire tool. Now coming to the results, I have found that not only in the children with ASD, ADHD, and CP, all the children like those who are diagnosed with Down syndrome, specific language disability, they are having the sensory issues. Among all the children, the autism spectrum disorder, ADHD, and intellectual disability children, they are having the more sensitivity in terms of hyper and hypersensitivity. Now coming to, this is the graph showing this same, and the domains which were assessed like visual, auditory, gustatory, olfactory, tactile, vestibular, and proprioceptions. I have found that the proprioception hypersensitivity and hypersensitivity, tactile hyper and hypo, and auditory hypersensitivity was found more among these children. And now coming to the behavioral pediatric feeding problem, I have found that 71 children are having behavioral feeding problem, and feeding problems which I have assessed was gets up from the during meal time, takes longer than 20 minutes to finish a meal and tantrums at meal time. These were the most common top 3 behavioral feeding problems which was found. And now coming to the parental perception strategies and the behavior or the behavior were problematic to them. Same, the children with ASD, ADHD and ID, they are having more parental problems as compared to others. Now coming to the correlation, it was found that the sensory sensitivity depends on the behavioral pediatric feeding problem, and it was statistically significant by using the Karl-Pearson coefficient of correlation. Now coming to demographic variables, it was found that the type of family, socioeconomic status and occupation of the mother, nutrition status of the child and diagnosis of the child was found to be statistically significant, and I can say that the sensory sensitivity depends on these demographic variables. Same with the behavioral pediatric feeding problem, the occupation of the mother, nutrition status of the child and diagnosis of the child depends on these behavioral feeding problem, and various studies were also assessed, but this is a study which concluded with the 6 demographic disabilities, the children with disabilities, and their same depends upon the demographic variables such as type of family, socioeconomic status, occupation of the mother and nutrition status of the child. Now coming to the impact, on the basis of this study, we have used a tool. We made a protocol for screening the sensory issues and behavioral feeding problems and nutrition status of the child, those who are arriving at the child development center, and then further studies was carried out to validate a tool that is to be used in the child development center and other settings, and education of the mother. I have provided with another booklet to the parents after completion of the interview, so that they can to know about sensory issues and behavioral feeding that eventually leads to malnutrition and other problems. So after the conclude the study, early and individualized sensory assessment is done, community awareness and participation is to be done, and education of the family and other personnel to be done, and multidisciplinary approach should be applied using all the occupational therapists, nutritionists, psychologists and child neurologists along with the sensory interventions and nursing interventions. Thank you.
Good study. Just my query is because I have seen your annual is parent perception. Your sample looks, it is children. Okay. What were your challenges faced in collecting data from this particular children?
For interview, it took around 45 minutes, ma'am, because after nutritional assessment, parents really don't know about the sensory issues. They are more concerned about the mobility of the child, like in CP children, about the activities of daily living, the speech problems and other problems. So they really don't know about the sensory problems which they are daily facing. So I need to understand them in Hindi, what are the sensory issues and how you can overcome by using effective interventions.
So ultimately your samples are parents, not children.
Yes, sir.
Yeah.
So 150 children, I have taken the nutritional assessment of the children and then interviewing with the parents.
Okay. So parents and children, both are your samples.
Yes.
Okay, in the outcome you said, there is an enhancement of sensory sensitivity among some groups. And how long, this sensory sensitivity enhancement was remaining there? Did you check?
Sorry.
How long it was persisting? You have checked it after your intervention. Just once?
Assessment, ma'am?
Yeah.
Yes, ma'am. First, after taking the anthropometric measurement, it took around 40 to 45 minutes for interviewing. And after the interview, the parents are provided with the booklet that is in Hindi for knowing more understanding about these sensory issues and behavioral feeding problems.
No, intervention is over, fine. And then you checked the sensory sensitivity, right? And again, second time or third time after a period, did you check?
Yes, like parents usually ask that whether the child, mostly they are concerned about the weight and the height and what is about the nutrition status. Now after giving the booklet, they are more concerned about what are these issues and how we can overcome them, how the effective therapy is to be taken and where is they go. Thank you, ma'am.
Thank you, Ms. Brahmana. Now over to Sharon Joseph.
morning, everyone. I thank Annie for the platform and I thank my principal, Professor Dr. Rosalind Rachel, for giving me this opportunity to do this study. Moving on. The Institute of Medicine and World Health Organization defined patient safety as absence of preventable harm to a patient during the process of healthcare and the reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. Patient safety culture, it is considered to be a central aspect of organizational culture, institutions' development and safety performance. Though it is primarily based on individual commitment, it does have an important impact on staff attitudes and behavior, especially job satisfaction. Every year, 134 million adverse events occur in hospitals in low and middle income nations, resulting in 2.6 million deaths. The work environment and working conditions of nurses are among the important factors that affect PSC. Findings indicate that nurses' work environment pose a threat to patient safety due to heavy workload and low job satisfaction. Thus, the problem statement, a study to assess the perception of patient safety culture and job satisfaction among emergency and critical care nurses at selected hospital in Chennai. The following themes and objectives were chosen to assess the perception of patient safety culture and job satisfaction, to find the relationship between mean score of patient safety culture and job satisfaction, to associate the mean score of patient safety culture and job satisfaction of emergency and critical care nurses with the selected demographic variables. Operation definitions, perception. There is a subjective belief or thinking with regard to patient safety culture and job satisfaction. Patient safety culture refers to the values, beliefs, norms of the emergency and critical care nurses that influences their action and behavior related to patient safety. Job satisfaction is the level of contentment the emergency and critical care nurses feel for their job. Assumptions made were nurses working in emergency and critical care units may experience increased workload. Prolonged increased workload may negatively impact job satisfaction. A safe, supportive and collaborative workplace promotes job satisfaction, which in turn will improve the patient safety culture among emergency and critical care nurses. The materials and methods. Contact approach was used with non-experimental descriptive correlation design among emergency and critical care nurses in unit of selected hospital with 80 nurses, and non-coordinating purposive sampling technique was used. The following were the demographic data. The tools used were survey on patient safety culture, which is a Likert scale consisting of 35 items. It had 10 components each. The scoring was as follows. More than 75% is referred to as high level with strong patient safety culture, 50 to 74% moderate level with moderate safety patient culture with room for improvement, less than 50% is low level with weak patient safety culture requiring immediate attention. With regard to job satisfaction, nursing workplace satisfaction questionnaire was used. More than 75% is referred to as good job satisfaction, 50 to 74% is moderate, and less than 50% is poor job satisfaction. The findings were as follows. With regard to frequency and percentage distribution, majority of the age group was in 19 to 23 with 51.2%, majority were female 77.5% and unmarried also 77.5%, BSc nursing with 83.7%, critical care unit was a dominant working area with 82.5%, majority was staff nurse with 78.7%, with experience of 1 to 3 years 36.2%. And more importantly, moving over to the working hours per week, it was 40 hours, 61.3%, and past 12 months reporting of patient safety events, 41.3%, and patient safety rating, 40%. With regard to perception of patient safety culture and emergency and critical care nurses, the assessment found was, under the 10 components, 5 components were found to be high, such as teamwork, communication about error, reporting patient safety events, hospital management support for patient safety, handoff and information exchange. Whereas, staffing and workplace, organizational learning, continuous improvement, response to error, supervisor, manager, and clinical leader support for patient safety, communication openness were found to be in moderate category. And the overall patient safety was found to be 60% that is moderate, and 36.3% were found to be high, and 3.8% was found to be low. With regard to job satisfaction, we see that 57.5% was having low job satisfaction, 35% had moderate job satisfaction, and 7.5% had high job satisfaction. And with regard to correlation, it was found that the relationship was inversely proportional for patient safety and to job satisfaction. And the following association was found: age, education qualification,
current designation, total years of experience as a nurse, and experience in this hospital, as well as current area of work, all predominantly were in 1 to 3 and less than 1, and significance with regard to patient safety culture, whereas with regard to job satisfaction, reporting of patient safety events and patient safety rating was found to be statistically significant. Nursing implications, promoting open communication using a just culture, error prevention and learning through CAPA and root cause analysis, collaboration, teamwork, leadership and support, workload management through proper working hours, professional development through CMEs and in-service education, which will lead to autonomy and empowerment of the nurses. The following were the recommendations. The limitations found were the sample represented mostly the junior staff nurses with less experience. There was difficulty in data collection, being the staff being busy in the respective areas, and it was focused on one particular unit, and only one particular group of healthcare providers. Hence, the generalization of findings is limited. In conclusion, overall patient safety culture is moderate, emphasizing the need for improvement, and overall job satisfaction is poor, and hence requires development of prompt identification and implementation of diffusion strategies from the workforce with appropriate backing from management in a non-punitive environment to ensure delivery of safe care to patients with highest form of responsibility, commitment and contentment. The following are the references. Thank you once again for this opportunity.
Congratulations again. I don't have any question, but just a comment. Can you go and see it? In your demographic data and all you had mentioned that there were no nurses from the emergency. They were only from ICU. But when you did the analysis, you did the comparison between two. So I might be wrong also in seeing the slide, but please go and check.
Yes.
Okay. Yeah.
We have seen your limitation of the studies. Can you tell us what are the delimitation of the studies?
Well, delimitation that I found was getting the staff to, initially we planned it as a study where I go in and collect the data, but collecting the data individually was finding it to be difficult, so then I had to change it to a Google form, and within the time period they filled it and sent it back to me. Thank you.
Thank you, Shari. Our last finalist, Ms. Joy Casey.
Very good morning. This study will take us through the impact that a patient acuity scale has in our hospital setting. Basically, we know that patient safety by safe, equitable nurse-patient ratio is something that we really want our nurses to practice. Patient acuity simply means the measure of a patient's severity of illness or medical conditions. And an acuity system typically identifies the amount of nursing care needed for each patient on a unit, on the level of intensity nursing care and tasks needed for the patient. So this system particularly allocates based on patient needs, not according to the raw patient numbers or nurses' experience, which is very traditional. And an acuity tool, on the other hand, promotes clinical expertise by making sure we enhance nursing competence based on patients' medical complexity, ADL dependency, etc. So the aim and the objectives were typically here to understand the patient's clinical needs, then to analyze the nurse's competency, and thirdly, to produce staffing patterns based on patient's AS score. So materials and methods we used, number one was a descriptive qualitative study which was conducted in our coronary care unit, only among 20 nurses, for a period of 3 months in 2024. The process measures, we used the patient acuity tool based on ANA. Then we also made sure the nurses were checked for their competency, their skill matrix was developed. We gave them training and then we put them for patient care. Technology measures, all of this was started on paper until recently last week we've also become digitized. Outcome measures here we realized assigned nurses felt at ease. Their training and OSCE stations greatly improved young nurses in performing
critical procedures independently and competently versus many years of experience of nursing. Then the handoff register between nurses allowed every nurse to validate a patient's current acuity and care needs. And the last measure was people measures where a nurse's competency matrix, skill enhancement and assessment was equally discussed with our HODs of medical teams as well as our nursing middle level managers. So figures and graphs, yes, we do understand that nurses were dissatisfied. They felt they were, unnecessarily given the same patient or the patient group was very high. They were unable to complete the tasks on time. Nurses felt they needed help. They felt they were incompetent. They felt they were unsupported and consultant complaints were constantly on a high. So this is the tool that we used. On the left side you see the clinical patient characteristics versus on the right you see the nurse's workload indicators. So a patient who falls into a stable category would have an assessment based on basic assessment, respiratory, cardiac, medication, drainage and pain management. And a patient who falls under moderate risk, which is category 2, will have these parameters. Patient under category 3 termed as complex, and patient under category 4 which would require high risk patient care. So basically a patient who falls under high risk patient care category would require 1:1 nursing care. 3 could afford 1 nurse taking care of 2 patients. Sometimes we still assign 1:1 if it is an isolation patient. For moderate risk patients, we can happily give 2 proper competent nurses. And for a stable patient, there is no requirement of 1:1 at all. So on the other side, if you see the nurse workload indicators, we look at the basic procedures that a nurse is competent with: admission, discharge, transfers, education and psychological factors. We look at wound ostomy and continence care. We look at activities of daily living and isolation practices. We look at safety, and then when the patient score is this, depending on this is how the nurses are assigned. So this is how we've gone basically digital. So our intranet actually, if I open my ICU, these are the bed numbers, and the names are auto-filled because they are already admitted into the system, and the gender is there, diagnosis is there, primary consultant name is there. And the entire acuity tool is part of the intranet, so the nurse manager just has to click what is there and finally she gets a score. So once she knows what the patient acuity score is, then she will be able to put a competent nurse. So how do we do the competency assessment? Again, I've given you a screenshot of what we follow. So this is from my ICU. We made team A, team B, team C, so morning, evening, night shift teams. So you have more of greens, which means they are more competent. We also have a healthy mix of yellows, which are, they can perform procedures with minimal supervision, which is partially competent, and an NC which cannot perform procedures without supervision. So this is just a snapshot of our competency checklist. And the assessment tools, I think most of us would use this. Self-evaluation on the day they join us, then of course the evaluation that's done by in-charges and by the nurse educator, and in this particular study we've been doing it on the day they join us, and then 6 months, 1 year. So this is how some of these pictures to tell us that we taught them. So this discussion was an iterative process. We're looking also at complete digital patient assignment. The whole hospital now is following patient acuity tool, not just in ICUs but also in the wards. And we're very happy that it has gone digital, so we can do away with our paperwork. And nurse managers initially found it time consuming, but now they're pretty much very happy that this is there. And our consultants are really happy that a competent nurse is assigned to a sick patient rather than just a namesake manpower standing there. So the results, yes, among the same 20 nurses, we felt a very marked improvement. So the presentation of results, the charge nurse and the script level nurses were able to efficiently use the patient acuity tool and map their own staff with competency ranking. They were able to regularly follow staff scoring against patient scoring. They were also able to understand how the assignments were given. There were a few challenges, but I think we've overcome them, and now the whole team realizes that a patient acuity tool really empowers our nurses and also helps us to place the right competent nurses for our patients. Thank you.
Very good study, very good. All of you have done very good, but I just have a quick question for you. When you have mentioned that you give that the training to the nurses on the high acuity nursing, what's the duration of the training for the nurses? The training. You have mentioned that you have given the training to the nurses on the high acuity nursing. What's the duration of that training?
7 days. 7 days was their training. 7 days was our induction training, which was extremely scheduled and it was organized. And then they moved in for a 3 weeks of preceptorship training.
So this is separate from your induction program?
Yes.
It's only on the high acuity nursing?
Yes.
Thanks. And then you have already mentioned that the challenges only for the, but what are the challenges did you face from the nurses in this?
From the nurses, it was very difficult because our nurses always felt manpower was less. And they said, ma'am, 1:1 we are not able to give. We are having to do double shifts. But when the patient acuity was actually told to them, and you know, for them it was like a mental breakdown to tell your patient doesn't need a full nurse all the time. You can actually come out, step out and take care of another stable patient. It was a little bit of a mental shift that our nurses had. It was difficult, sir, as you said, but middle level managers were able to appreciate it. I think multiple times of our connect and going on rounds really helped them.
Thank you.
What type of a study was it? You said it was a qualitative study. Was it a qualitative study? Descriptive. Initially you mentioned it as a qualitative study, so I got a little bit confused because your tools were having numbers. Okay, thank you.
Thank you.
Just a comment. When we report, we don't write the name of the nurses and the doctors. Okay, because your slide had the names of the nurses and doctors. I do not know what was the specific reason, but just a comment. It's not a correction.
I think I'm not able to follow.
Oh, you have written the name of the doctors. They were looking after the patient, you know, in your slide.
Okay.
Ethically, it is not taken
Probably
into the
mistake.
It's just a comment.
Sure, thanks.
So that concludes the presentations. So thank you to our esteemed jury and all the presenters for their, great presentations and their valuable inputs. We now request all participants and judges to gather for a group photograph on the left side of the stage. All the presenters.
Thank you very much. And after that intellectual Tiruvadira of paper presentations, it's time for some real Kerala classic chai. So please go ahead and enjoy your